physiology, and I'm just going to use this opportunity to talk to you a little bit about my research project that I'm conducting as part of the programme. So the title of the research project that I'm doing at the moment is Temporary Epicardial Pacing Post-Cardiac Surgery, and it's an audit that we're conducting here on the 1C ward upstairs. So I'll start by giving you a little bit of a brief background, covered then by the aims of the project and what I hope to achieve. Briefly talk to you about the methods in which I've used to plan the audit and also to conduct data collection, what I found so far from the results that I've obtained, and what I propose the next steps might include. So in terms of background, I'll just get this up for you. There we go. Temporary epicardial pacing is basically something that's quite commonly inserted post-cardiac surgery to provide support to the patient in terms of their hemodynamic stability. So this can help to treat arrhythmias that might negatively impact patient morbidity or mortality during the post-operative phase. So it's usually put in at the same time as the procedure is done. And it can then act as a bridge either until spontaneous recovery of these arrhythmias or until a more permanent solution may be found. So that might include insertion of a pacemaker. The reason why this audit is important is because there are risks associated with suboptimal programming of the temporary pacemakers, and these are the main three risks here. So if they're not programmed appropriately for the patient, they can actually risk inducing atrial and ventricular arrhythmias, so arrhythmias from the top or the bottom chambers of the heart. Obviously this is something that we don't want, because following on from that you can have reduced cardiac output, leading to a longer recovery period and a prolonged hospitalisation and ITU stay. The risks that might lead to those risks include loss of capture. So basically the pacemaker is programmed in such a way that it will deliver a certain amount of energy to make sure that when it delivers a pacing impulse, the heart will contract. If your programming is suboptimal and doesn't necessarily meet the safety margins, you risk loss of capture. So the pacemaker might believe it's delivering pacing, but it might not actually be causing any depolarization of the heart muscle. So the risk here is that if you've got a patient that's pacing dependent and the safety margins aren't met, then they might not actually be receiving any therapy from the temporary epicardial pacing. The next risk I've listed is oversensing, so that's talking about the device's ability to see the patient's intrinsic heart rate. So if it's oversensing, it's basically detecting non-cardiac signals but not being able to tell that they're non-cardiac. So if the device thinks that the heart is doing the job itself, it will withhold its own therapy. Again, the risk here is if the patient is pacing dependent, if it withholds therapy, then actually underneath the noise might be a patient who's asystolic. And finally, undersensing, which is demonstrated from this picture here. This is the opposite of oversensing. It's not, the sensitivity value is set too high so that it's not actually seeing any of the heart's intrinsic activity. Therefore, it thinks it's not doing anything and it will just deliver pacing regardless of what's actually going on underneath. The risk here is that if you deliver pacing during the refractory period of the heart, it's quite a sensitive time interval, and it can actually induce patients into life-threatening arrhythmias, like it has in this picture here, into ventricular fibrillation. Oops. Audit aims. So the reason why I came to doing this audit is basically centrally to improve patient safety, and the only way that we can do that is to assess what the current situation is at the moment with the management of these patients on the ITU. So the purpose is basically to create a snapshot of management of these patients on the ward, and by knowing where there might be room for improvement, we can put in measures to help reduce complications in the long term, reduce length of stay, and all that will have the net effect of hopefully improving patient safety in the long term. In terms of methods, the first step was basically to come together with the relevant stakeholders involved, so that included the ITU matron, the lead consultant on the project and clinical educational leads, and get relevant buy-in from an early stage to get support on the project. And then once that was obtained, we registered the project with the clinical effectiveness unit here at Barts. Once approved and ready to get going with the project, the next step was to create a database for data collection. So that entailed a spreadsheet which recorded the current settings of the pacemaker devices for for the patients, and then sections to assess the atrial leads, so the leads going into the top of the heart, the ventricular leads, the leads going to the bottom of the heart, and other programming parameters such as the mode. In terms of assessing these for safety, in general terms, a twofold safety margin is applied. So for the output threshold, the minimum energy needed to be delivered by the pacemaker, you'd expect that the output program would be twice that. And similarly, for the sensitivity, you would expect it to be set at half the amplitude of the waves it's supposed to be seeing. Observation of ward rounds then followed, so I spent some time with the consultants on the ward to see what their day-to-day workflow was like and the roles and responsibilities of the staff involved. And finally, data collection started in about January of this year and continued until November. In terms of the results I've obtained so far, there's 120 patients in the audit so far, in the audit in total, and 35 patients have had at least one element of their temporary pacing which could have benefited from adjustment. So it might not be that they are inappropriately programmed, but they may be deemed suboptimal if they haven't met this twofold safety margin. And actually, of the 35, 7 patients had more than one programmable parameter which needed adjustment. So an example of that might be a patient whose lead had a problem with its output and sensitivity rather than just the one. So it's quite a big chunk of patients who might benefit with their device being optimised. And then this table is a little bit information heavy, but it basically breaks down which patients had which kind of issues with their leads. So in terms of the patients with atrial wires, there were 55 in total, and of that, 20 patients had an aspect that could have been optimised. So there were 3 patients whose output was suboptimal, there was 12 patients whose sensitivity was optimal, and then there was actually 5 patients who had an issue with both of those. Similarly, with the ventricular wire patients, there was 90 patients in total, and this time only 8 required adjustment. 4 required an adjustment in output, 3 in sensitivity, and 1 in both. So it seemed to be a general pattern that with A leads, the bigger issue was the sensitivity being set incorrectly, and for the V leads, the output. In terms of mode, this was assessed according to the ESC guidelines that we use for pacing and mode selection, and out of the whole 120 sample, there were 9 patients who had a mode that could have been optimised. The example of a patient who might benefit from mode switch was patients with complete heart block, and they may have benefited from having a DDD setting rather than a VVI setting, just as an example. In terms of the next steps, it's quite clear from the graphs that there is a sense of suboptimal device management of the patients at the moment, and at Barts we don't have a physiology-led support service to the ITU patients or ITU medical staff. So the plan here is that we could increase the education available to the medical staff on the ITU, increase their confidence with the devices and understanding some of the concepts involved, and also to produce a standard operating procedure. At the moment, we don't have a standard operating procedure in place, and so we feel like this might be something that could be beneficial for patients going forward, because it would encourage consistency in the management of these patients. And then finally, there's then scope to perform a re-audit in the future to see to assess basically the outcome of putting these measures in place on patient safety on the ITU. So in a nutshell, that's my project for the STP. Thank you for listening, and if you have any questions, then fire away.